Great. Well, thank you for everybody that's joining us. Hope that everybody's doing well and that there's not anything exciting in your life like fires or COVID or anything like that. So what we'll be doing today is talking about clinical epidemiology and why we should care about it, what the outcomes are. So what we'll be talking about the two main areas will be diagnostic tests as well as in a clinical medicine setting. Now, when I was preparing the talk, I was all excited because for those of you that are familiar with the ProMed listserv that covers all the epidemics and diseases going on around the world, I thought there were a lot of cool things related to COVID-19. But the more I got into it, the more I realized I really didn't have the time for wallowing a lot in this. But some of the themes that come up basically fall into the category of where was COVID-19 occurring, how many people are affected, what's the accuracy of the tests, what treatments work, things of that nature. And those are all things that are covered under clinical epidemiology. So why are we talking about diagnostic tests? The reason why would be if you're developing a test, you might want to use it for clinical diagnosis. You might want to use it for screening people for who might have a given condition. Might be used for population surveillance, epidemiological studies, or risk analysis, such as is there a risk of COVID being introduced or something of that nature. So those are all things that you want to keep in mind when you're developing a test. So one of the things I'd like to go back to the beginning to make sure that we're all on the same wavelength is to realize that there's different types of diagnostic tests. So even a physical exam, whether you're listening to the heart or listening to the lungs or feeling whether there's warmth or swelling, that is a type of diagnostic test. Tests that we're a little bit more familiar with are those that are looking at a chemical or cellular level for any abnormalities, say in the blood or the cerebrospinal fluid or things of that nature. There can be physiological tests such as an electrocardiogram or lung function sorts of tests. Where I have a particular interest is infectious diseases. And two general categories are tests that identify the agent or indirect tests that identify the antibody response to the agent. There are genetic tests that are being developed for various conditions and are being used for various conditions. Then also imaging is another type of test, meaning if you're doing an X-ray or ultrasound or things of that sort of thing. So an important thing that we want to talk about and consider is how accurate that diagnostic test is. And there's a couple of clinical epidemiology concepts that I'd like to make sure we're all familiar with. One of them is sensitivity, and that's proportion of affected individuals that are correctly classified as affected or infected. And then there's specificity, where if you're looking at those that are not affected or infected, and how many of those folks are correctly classified. So this 2x2 table helps a little bit in terms of hopefully clarifying that concept. So if we have an individual, they can be either positive or negative for a given condition. And then we've got a test result, which is either positive or negative for a given condition, recognizing that there is potential for false positives, false negatives. But in terms of sensitivity, that means that all the individuals that are affected are also test positive, whereas all the individuals that are negative are also test negative. So obviously, we'd like 100% in both of these categories. Some tests may come close to that, but it's usually not close to, they usually don't come close to 100%. Now, these 2x2 tables can be a lot of fun for all kinds of mind-numbing calculations, but I've been informed that mind-numbing is not allowed for these sorts of webinars. So we'll just leave you slightly excited about what could be done with these sorts of things and move on a little bit here. So one thing I want to make sure, because many of you are in the business of developing diagnostic tests, are the difference between clinical epidemiology concepts And then those in analytical terminology that would be used in the lab. So in the lab, when you're talking about sensitivity, what you're usually talking about is the smallest detectable unit of change, whether it be biochemical parameter or physiological parameter, things of that nature. So that differs from what we were just talking about with the test classification as being accurate. The other place is with specificity, which is a little bit more similar to the specificity that we just talked about, but it's a little bit more concerned about misclassifications for reasons such as cross reactivity or other things that can happen within the test. So we run a test, and again, in terms of general categories, we're going to have two different types of tests. One is dichotomous, or types of outcomes. One is dichotomous, which means either test positive, test negative, things of that nature, or we can have quantitative tests, which is something that a lot of labs are going to run. A dichotomous test would, where say something in the clinic where it changes color. Some of you may be developing, but let's talk a little bit about more about the quantitative tests. Now, the concern that we've got with a quantitative test, meaning you've got a series of numbers, is the cutoffs are somewhat arbitrary. And that's something that kind of burst my bubble the first time I got into one of these studies, when I asked one of my mentors how he decided what a cutoff was. And he basically said, well, he established it based on what he thought was right. Well, that wasn't entirely satisfying to me. And since I've learned more, basically what it boils down to is there always is going to be an arbitrary component. But what's important is to understand and be transparent about what it is that you value or prioritize and what the trade-offs are that you're willing to accept. So let's explore this a little bit more in a little bit more detail here. So here we have our standard bell-shaped curve that everybody's probably seen before. And so let's say we are running a biochemical test for sodium or potassium or liver enzymes or anything like that. This is our standard bell-shaped curve. We're going to call this population everybody normal. But because we are usually saying 95% confidence level is what we're looking at, by definition, 2.5% below the curve, and I'm sorry, I have trouble keeping the cursor up here, 2.5% below the curve and 2.5% above the curve. By definition, if we have this normal population, or 5% total, are going to be classified as abnormal right off the bat. So what does that mean? We have 100 normal patients, and let's say we have 100, each one of these normal patients receives a 20 test panel, like a lot of biochemical panels that doctors may run. And each test has that 95% reference range. The question that I'm throwing out to you is how many of these 100 patients are going to be classified as normal for every single test on average? So your options are, and this is going to be a poll, 100%, 95%, or 36%. So time to go ahead and vote. And your lives don't depend on this, so make a choice, and we can then move on and talk about it a little bit more. Okay, so looks like everybody's voting for 95% here, and nobody voted for the others. 95% makes sense, but if you do the math, let's say you look at the first test for a given person, 95% of the people are correctly classified. Then of that 95%, another 95% for the next test, and so on. So the way to deal this is a power calculation. If you do 95% to the 20th power, then it works out to about 30%, 36% of those individuals actually are going to be classified as normal within that reference range for every single analyte. Now, in the real world, an experienced clinician is going to say, well, gee, um, they sort of know that, and particularly for values that are just outside the reference range, they're probably going to ignore it and look at some of the other um, factors that are involved with that. So as an example, if it's just a single calcium that's slightly out of whack, they're going to probably ignore it. Whereas if it were a bunch of liver values that were all just barely out of normal, they might want to look a little bit closer and think about it a little bit more. And I'm not able to progress this. Samuel, I'm hitting my arrow here. Let's try
Could you
this.
click on that
There
now?
we go. I'm sorry. And then what I was just talking about worked for continuous values, but if you had a histogram of discrete values, you'd still have a similar challenge in terms of where you're going to call this cutoff. So that's basically a real world challenge and something to think about when you're developing your lab assays. So the reality is that there's always going to be a trade-off between test sensitivity and specificity, and um, and that's going to be basically a function of that cutoff. And so there are a number of different ways of dealing with this. One that I'm going to raise is receiver operating curves, which is actually kind of interesting, is borrowed from military operators back in World War II. And basically what we're looking at with this graph is, let's say we've got the false positives here graphed against the true positives. And with this straight line here, what that basically is 50% for each of them, which is basically equivalent to tossing a coin, which means we have a test that really isn't of much value. Now, a better test is if we're a little bit closer to being in this upper left-hand corner, where all our true positives are right in line, and then best is right up here. So um, the value here is that even though we still have to make these trade-offs, the value here is that at least we know we can do, there we go, calculations. So let's say if we want to maximize the number of individuals that are correctly classified, we can do area under the curve calculations, which would be right around here. But for other reasons, we might want to pick off a cutoff here or here. And the value of that is then that helps us decide how, at least we know what the impact of our decisions are. Now, in the real world, things are not as clean. Sensitivity is affected by the stage of infection or the immune status. So, as an example, let's say somebody were to cough on me with COVID or the common flu 10 minutes ago. We take the test now. The test is probably going to come up negative because I'm not yet infected. So, the sensitivity or the true positive is not going to be there until I develop a little further along my infection. Also, immune status. If somebody's immune suppressed, you may not see a response for an indirect test, such as an antibody test. And then if you're looking at specificity, we talked a little bit about cross-react agents a little bit in the analytical concept, and that crosses over to clinical epidemiology. With vaccination can also be a challenge. So one of the questions about COVID has been, if we develop a vaccine, can we tell who's been truly infected, who's been vaccinated? And that makes an impact in terms of monitoring how the population is dealing with the infection. But now the good news about COVID is it appears that we can distinguish, but that isn't always the case for some infectious agents. So what we want to do is part of this picture is we also want to validate these tests to see how accurate they are. What we always would like to have is a gold standard to compare by. That doesn't always work out that way. There's some nice mathematical techniques for estimating test accuracy in the absence of a gold standard, but just like with some of the other things we've talked about, we don't have enough time right now. Now, one of the things that's important when you're validating that test is what population are you sampling and how are you sampling, and the sample size, which obviously I'm sure most of you think about when you're developing a test. Also, an important part of the picture is repeatability and reproducibility. If you were to repeat the test again the next day or the next month, or if you compare test results between different labs, are they going to be pretty comparable results, or do we have a problem in terms of consistency? Now, again, because this is the real world, things can get even more complicated. So what we were talking about was test sensitivity and specificity. That's a test characteristic that isn't necessarily static. It will vary by population. And so that's why the concept that comes into play is also predictive value of true positives. So when you're testing an individual and it comes up positive, how confident can we be that it truly is positive? And then there's proportion of true negatives. How many people, if they test negative, are going to be truly negative? And population infection rate is also involved with this as well. So that doesn't sound necessarily entirely doesn't entirely make sense. The term here is population prevalence, which means at a given state and time, how many individuals are truly infected. So the way this works is if we were to look at a graph and we were to graph disease prevalence against the predictive value of that true positive, that predictive positive test or negative. So if we think about it, if the disease prevalence is 0 or close to it, and you get a positive, then the positive predictive value is going to be basically 0 because the odds that it's correctly classifying somebody as a positive are pretty low. On the flip side, if everybody's infected in a population and you get a positive test result, yeah, you're pretty much sure that you are right on track. So we don't want a straight line for this graph, just like with the graph that we showed a little while ago for the ROC. The further this central area is up to the top, the better. Now, the same thing is relevant to the negative predictive value, whereas if nobody's infected and everybody gets a negative test value, yeah, you're pretty confident in that value. And then vice versa, if disease prevalence is 100%, you're not going to expect many that are going to be correctly classified if it says positive. So again, we're going to want the curve for this to be up closer to the corner here if we have a better performing test. So here's another poll for everybody. Given the graph that I just showed, is it practical to have an in-house office test for both influenza and anthrax? And your options are yes, no, or for those of you that don't want to commit, we've got a third option too, and you don't necessarily have to commit. And so we will see how we're doing on this. Okay, so we have a few people that want to make a commitment, and many of you say no, which is the correct answer, because the reality is that anthrax is an uncommon disease in most settings. So if we get a positive, it's going to probably be a false positive given what a serious disease it is. There's going to be a lot of excitement, a lot of concern. So routinely testing for anthrax is probably not a great idea. On the other hand, testing for influenza, um, it's fairly common and it may have some value for us. So let's make things even more complicated, not to blow your minds and not to imply that tests are never accurate, but in terms of developing a test and interpreting a test, there's some additional things that we need to think about in terms of populations. So these are some of the questions that might be of importance to a population. First off, is the disease present? Is COVID, back in the spring, was COVID present in the United States or any other country? If it was prevalent or wasn't present, how many people are affected? And what's our confidence levels there? How accurate is that test? Or if nobody was here, was the risk of introducing disease into that population? So we could potentially use the same test for each one of those questions, but the interpretations and how we use them may be a little bit different. So if we're picking out a test, things that we need to think about, if we have a range of different tests, what's the goal of the testing? What are the test characteristics in terms of accuracy, as we talked about first? And then we talked about how the prevalence of infection or disease in the population can affect that. And what ends up is the predictive value. Then the new concept that we're going to talk about briefly is the cost of the test, because depending on the impact of the disease, the cost of the test, that could make a big difference. So if we have a disease that's very common and the test is very expensive, we might not run it. If it's a very uncommon disease, such as maybe a birth defect, it might be worth finding out early on and paying that extra money to find out what we need to be doing to address this. And then, of course, related to that, the segue is the impact of that testing. So like I implied before with the anthrax, if you've got a positive and it's a false positive, that has a pretty dramatic effect on the patient. And what you really want to do is, before you report something, have a pretty good idea where you're at and where things may lie in terms of an impact, and be selective about how you use a given test. Now, so one of the questions undoubtedly comes down is you're probably questioning about a lot the accuracy of these tests and the applications, all the different uses. And one of the ways we can increase our test accuracy is by using multiple tests. So one way of doing things is to have more than one test. And the challenge there is that we're assuming that the tests are independent, and that would be valid in a case such as if we were comparing a classic histopathological lesion with maybe a serological test. In that case, we're probably independent. In many cases, there's the concept of conditional dependence because the tests are not completely independent. So what do I mean by that? Well, let's look at our friendly neighborhood germ. And let's say we're looking at an antibody test. One test is looking for an antibody that's on this part of our friendly germ here. Another test is looking at this. So these tests will very likely perform differently, but are they completely independent? Probably not. If these are integral structures that are part of every germ that we're testing for, they really aren't completely independent. So that's one concept to keep in mind when you're evaluating your tests. Another thing is, how are you going to use different tests in the field? So one way is in parallel, meaning that you use both tests or more than one test, more than two tests at the same time. And if one of them is positive, then you classify that individual as as being positive for that condition. And because one of two or many is positive, what we're for that condition, what we're doing is we're basically increasing the sensitivity of those tests or the positive predictive value. Um, Actually, excuse me, just the sensitivity, simply because um, if there's somebody that's positive, we want to find them by one of the tests. So by using multiple tests, then we're increasing that sensitivity, most likely identifying those that are truly affected by the condition. Another way is to test in series, meaning if one test is positive, then you do another test and verify that it's positive, or maybe even a third test if that is the case. And what that does is that increases the specificity, and that's a nice thing. So let's say if whatever you're testing for is a really bad disease, and something that you're really concerned about, whether it be anthrax or anything else. What that means is that if you get a positive, by increasing the specificity of that test, it increases the likelihood that you're correctly classifying that animal or that individual, that person, and you're less likely to have a false positive, which increases the specificity there. So I promised you that we would talk a little bit about clinical medicine, how this would be used out in the real world, for something to think about as you are developing and marketing your test. And so as a plug, if you want to go back to our evidence-based medicine um, um, webinar, a big thing is what is it that we're looking at? What clarifying our questions, and that could be very fine. So one of the recent things that came out on ProMed, one of the discussions over the last week and a half, is when do you use different drugs for COVID-19? And it turns out that some are better early in disease, and later in disease they've canceled those clinical trials because they don't seem to be helping the patients. So here are some of the questions that you can ask, and I'm bringing up this reference for a couple of reasons. One, I really like it. I think Sackett has a lot of great ideas that are explained very well. But also the date is deliberately old, because what I'm throwing out for the most part really aren't new concepts. They're things that have been around for a while, particularly for people that maybe were trained before this time, or maybe weren't familiar with this. Sometimes I've had a little bit of challenge getting people up to speed on some of these more recent concepts. But anyway, some of the questions that can be asked from a clinical epidemiologist perspective when you are evaluating published results. One was an inception cohort assembled, meaning did you identify people early in disease with a consistent definition of disease and then follow them through for a study, which is much more accurate than, say, a retrospective study, where you're usually going to have a little bit more general definition of what a case definition is. So another question is the referral pattern. How do those patients get into that study? Were the patients at a tertiary care facility, primary care? Was it from a wealthy community, a poor community, things of that nature? Again, this may not be entirely intuitive. So let's look at this graph here. What I'd like for you to look at the x-axis, where we've got clinic-based studies compared to population-based studies, and looking at seizure incidents after an initial event of a seizure. And you'll see that in the clinic-based studies, they're reporting that seizure recurrence is going to be a lot higher than in the population-based studies. So is this because these folks are being looked at more closely, or is it that they were referred to the clinic, maybe a tertiary care facility, simply because they were more susceptible to having another seizure incident, or is it some other explanation? So that's an example of how the referral pattern can be of relevance to interpreting a given study. We can also look at was complete follow-up achieved? If there were dropouts along the way, then that can potentially influence the results, particularly if you have a small study population. And it can obviously influence the results either way, but you really want to be able to follow people all the way through a study. If not, then that's going to be a little bit of a question mark, and you're going to be a little less confident in the results of that study. And then another thing would be, was there an objective outcome that was being examined and reported for that study? So how explicit was that? So if you have something general like GI disease, well, that could encompass a number of different clinical signs. Whereas let's say you are looking at something more specific like vomiting or diarrhea, well, that's probably going to narrow the range of diseases a little bit further. And in a case like that, again, you can be a little bit more confident in the results. So as I think most people are aware of, studies that are conducted blindly are going to be better because we have minimized the odds of biases. And then also the extraneous prognostic factors. So let's say we're talking about a variety of signs like we did a few minutes ago. Could be that somebody has multiple conditions such as heart disease and diabetes, or maybe COVID and asthma, things of that nature. Did the study account for those extra things? And so hopefully as a part of the clinical medicine picture, what we also want to do is use clinical epidemiology to pick the best therapy. So questions that we're going to have are, what is the objectives of treatment? Are we looking for a cure, or is it something that's not curable? And what we really want is symptomatic relief, or basically a long-term preventative would be something that we'd be looking at with that question. In terms of selecting the best treatment, a lot of times that would seem to be common sense, but let's think about it. Let's say it's something that's really not causing a problem. So maybe somebody has a mild case of acne and they can live with it. Do they want to spend the money? Is it worth the benefit there? And also compliance is an issue. If you've got something like tuberculosis, where you have to have the patient needs to be highly compliant over a long period of time, that creates a challenge in terms of whether that's the ideal treatment. And maybe you want to pick something that's maybe not quite as effective, but gets around the compliance issue. And then, what is the treatment target? An obvious question is, when do you stop? In an ideal situation, you're cured and you know when to stop, or you have some other sign that it's time to change course and pick a different therapy. So for our conclusion, a lot like with our evidence-based medicine talk that we gave a few weeks ago, where we're talking about, yes, there's science involved, but there's also clinical judgment and patient values, and all those roll into what is the evidence, the science part, what are the objectives in terms of the patient values and the clinical assessment, what are the trade-offs, which unfortunately are always there, and then for that particular value, that sweet spot in terms of which one of these science and clinical judgment values works, overlaps with the patient values in terms of meeting our objectives. So with that, I hope I didn't totally confuse you, and that at least we gave you an idea that there's some questions that you might want to think about in terms of developing or evaluating a test. And if there are questions, that'd be great. Either way, hope wishing the best for everybody during these challenging times.
Thank you, Dr. Miller. So if you have any questions, please feel free to put them in the Q&A section, or you feel free to put it in the chat and I'll pitch them to Dr. Miller. But I guess just to start off, how do analytical test sensitivity and test specificity fit in with clinical epidemiology?
So that's a good question. I probably should have gone into it a little bit more in terms of comparing the analytical values versus the clinical epidemiology. What I've seen with the tests that I've evaluated is what's reported by the lab is often the test characteristics are much more encouraging, meaning close to 100% accuracy for both positives and negatives. But then when we get out in the field, the values are not quite as good. And in fact, in some cases, being a lot closer to 50%, which, as we talked about before, is a lot like flipping a coin. So why would some of these things happen? Well, one would be one of the things I've looked at has been with mycobacterial diseases. In the lab, what they've compared have been the extremes, the end case individuals that were clearly infected compared to the individuals that clearly were not affected. And so the test may perform well for classifying the extremes, but in the real world, what we might be really interested in are those that are in between. Those are in the early stages of infection. We're not really clear from the clinical signs whether they're infected. And the important questions are, can we address the infection before it progresses and before it affects other people? So that's one instance. Another example that we talked about during the webinar is also cross-reactivity. Again, a mycobacterial example would be for tuberculosis. There's also a lot of mycobacteria that live in the soil that usually don't cause a lot of problems, but maybe somebody's a gardener and they're exposed to it. That might cross-react. Or in the news with COVID, there are a lot of other coronaviruses that cause childhood disease or gastrointestinal disease. And the question would be, if we're testing for COVID-19 and somebody was exposed to one of these other coronaviruses in the past, could that cross-react and interfere with the accuracy of our test? So those are a few things that hopefully will clarify your thoughts on those questions.
Awesome. I guess one last question. What are your recommendations for laboratories establishing cutoff values for their tests?
This overlaps a little bit with the previous question in terms of what we want to look at when we're testing is looking at a range of clinical disease and hopefully with other conditions as well. And so what you really want to do is decide how you're going to use things in the field. And one of the things to think about when you're developing a test is there's also the option of developing different cutoffs for different conditions. So as an example, a toxoplasmosis test that I ran once upon a time, when you look at the insert for that test, there was one cutoff for pregnant women, and then several other cutoffs for other conditions or other uses. Again, getting back to the questions that I posed earlier, what's important to you for a given individual or a given population in terms of the questions that you're trying to answer.